So just a little introduction to myself, because I've had an introduction from everyone else. So I'm Ryan. So I know Tim because we both used to do some work we worked as antimicrobial pharmacists across the East Midlands. So that's my, I guess, healthcare background. But I now work part-time at Montfort University as an associate professor of antimicrobials and consultant pharmacist for antimicrobials, and I do some work other days of the week for a specialist interest group called the British Society for Antimicrobial Chemotherapy. So the bits that I'm going to be talking about today is really related to the work that I do here at Montfort University, linked with the NHS across Leicestershire. Really is where the projects took place. So what I'm going to focus on talking about over the next kind of 15 minutes is really the three main, I guess, patient-facing sectors of practice within pharmacy. So we've got hospital pharmacists who obviously work across secondary and tertiary care in the NHS, but also private hospitals, but we'll be focusing on the NHS in this talk. Top right, you can obviously all relate to that. You've all probably been into a community pharmacy, and that's where the majority of our profession works. And whilst we've had pharmacists working in GP practices for a couple of decades now, it's only really kind of taken hold over the last, I'd say, 5 years or so, since the government has provided funding to GP practices to bring in pharmacists and pharmacy technicians to deliver care. So those are the sectors I'll focus on in terms of data and how we've been able to link not just within one sector, but multiple sectors to review our use of medicines and make improvements and changes to practice. So across these different sectors, in terms of pharmacy-specific data sources, there are many, and these are just few. So in the hospital, we obviously have a central role to play in supplying medicines towards dispensing medicine to individual patients, both during their admission and on discharge. And that has its own system, but that system doesn't always link through to other systems. So you can see none of the icons that I've got on the screen here actually have any lines joining them up, because they generally don't talk to each other. So some hospitals, if they prepare chemotherapy or parenteral nutrition in-house, they might use a different dispensing and management system that doesn't talk to or isn't part of the main dispensing system. There's also prescription tracking systems. So that's allows the pharmacy department to keep track of how long it's taken them to do discharge medication and stock orders, for example. But it also, if it's used right, allows the nurses to log onto that system to see where their patients' medicines are at in terms of, have they been dispensed? Are they ready for collection, etc.? That doesn't always talk to the dispensing system either. And then hospitals also have an on-call service, which is generally run by the junior members of the team, and a lot of hospitals, particularly the bigger ones, will have an on-call logger where the queries that come in overnight and out of hours are logged, and the outcome of that is also documented on the call logger, which allows the more senior members of the team to review it the next day and pick up on any issues that need to be followed up on the ward. And as expected, doesn't talk to any of the system. In community, we've got private providers that are providing dispensing systems. So Boots will have their own, Lloyd's might have something different, and independents will purchase their own in. So obviously they don't talk to each other. So in primary care, there's a very broken data structure going on there. There's referral systems. So the main one is Pharm Outcomes, which allows pharmacies to receive referrals from hospitals and GPs, but allows pharmacists to make referrals back out again and transfer information. That doesn't always communicate directly with the patient's GP records, and often has to be picked up by a member of staff in the GP practice. Some community pharmacies now have viewing rights and access to certain parts of the GP record, but aren't able to access everything and aren't able to generally directly input into a patient's GP record either. And then we have controlled drugs. So things like your opioid medications, they need to be recorded stock-wise and dispensing-wise in a particular register. That might be digital, it might be paper. And also there's private prescription registers and emergency supply registers as well. And again, they may be embedded within the dispensing systems or the patient record within the community pharmacy, or they can be paper as well. So there's lots of data in community pharmacy that isn't interlinked and that we're not accessing. As well as that, we have to recognize that pharmacy works within the greater health system, and in hospitals, we've got the data warehouse. So some of our data gets fed into that, particularly from electronic prescribing systems and from our stock management systems, can get fed into that central data warehouse. But in there as well, there's also, the patient journey, what's happened to them, and coding as well, can all be stored in the data warehouse. Laboratory systems, particularly for my interest, is the medical microbiology system, and I'll talk a little bit about how we extracted data from that later in the presentation. And then we've got our prescribing system, which, depending on which prescribing system you have, can draw upon and pull in different aspects of data warehouse, laboratory systems, and even some of our electronic prescribing systems now will directly link through to our dispensing system as well, which makes everything a bit easier. But not every hospital set up that way, and I haven't yet worked at a hospital where I've had one of these all sing all dancing systems. In the middle, I've put the NHS Business Service Authority. So FB10s, for those who aren't aware, the green prescriptions that you used to get in from a GP. When they're dispensed in a community pharmacy, they're then sent to the NHS Business Service Authority, who transcribe everything onto a database, which you can access. So all the kind of headline data from the prescriptions in terms of who prescribed it, where it's dispensed, what the product was, how much, etc., is all stored in this database. And you are able to, if you're doing particular research projects and you're doing audits, if you supply, if you pull that data, you get a prescription kind of code, you can send that back to the NHS Business Service Authority, and you can actually get copies and scans of the FP10s to do research from, which I've done in the past. So I'm going to talk about two projects that we've done, or I've done rather, in hospitals in Leicester. So it was when I worked at Leicester Royal Infirmary. Our first one was pharmacists on the emergency unit. So again, like GP practice pharmacists, pharmacists working in A&E, the emergency decision unit, etc., is a fairly new thing. It's only really been growing over the last, I'd say, 5-10 years or so. And one of the things that we wanted to prove in Leicester was that we were actually adding value. One of the things that pharmacists have always done in the past is kind of done an intervention log to show, oh, I've done this, I've given this advice to a patient. But it hasn't always told us or the wider hospital what our actual impact on patient care is and what the outcomes are. Getting clinical outcomes for this kind of data is difficult, and that isn't what we looked at here. There were another piece of work I did. We did look at readmission rate, mortality rate, etc. In this piece of work, our pharmacists were recording their interventions or their contributions to care. And we wanted to look at, from an economic and health system perspective, did having a pharmacist in A&E speed things up and get our patients out quicker and actually get the flow moving? Because Leicester's, I believe at the time, it was the busiest A&E in the country. So we had the pharmacy intervention log of what they were doing. We were able to use the prescription tracker to find out how long it took us to process those prescriptions. So the traditional route was our pharmacist would be in the dispensary on like their kind of dispensary slot, and the nurse would, or the HCA would bring the discharge prescription or the drug chart to us to review and then be dispensed, and then it would go back to A&E. The new system, obviously, all that could be done on the ward by the pharmacist and then automatically electronically sent to the dispensary for dispensing. We want to look at the discharge letter in terms of what changes and, again, interventions the pharmacist was making in terms of the discharge letter and when that had been processed and how quickly that had been processed. And we also use a data warehouse to look at the patient's length of stay, time of discharge, etc. None of those were joined up. So when we were collecting the data, we obviously had to think of a piece of data that could link all four sources together. And unsurprisingly, the hospital number was the easiest way for us to do that, and the date as well. So we needed to make sure that when we were extracting data from the prescription tracker, the discharge letter, and the data warehouse, we were using the right date that correlated to the pharmacist intervention log, because some patients are frequent flyers, come in now and again, or they may have been into A&E and then come back for a visit to one of our like we had a GP referral unit, which is now called like Miami in a lot of hospitals. They would often have multiple prescription tracking logs and data warehouse data. So we need to make sure we tie that up using the date. So when we brought all that together from a service perspective, so this is from a poster we presented at a conference, we found that by having a pharmacist actually on the emergency unit, seeing patients face to face, they saw more patients, which is better for our patients and better for the service. So they were doing a lot of jobs that were originally being expected for the nurses and the medics to do. So a lot of the medication reviews, doing the drug history, and getting them ready for discharge. The number of, I guess, contributions or interventions that were made wasn't different, depending on whether the prescription went to the pharmacy or stayed on the unit with the pharmacist there. But what we did find was the time taken to essentially get the patient out the door was massively reduced. So by having a pharmacist on the unit reviewing the discharge letter and reviewing the medication, it took them 11 minutes compared to 45 minutes for the remote service where the pharmacist is in the dispensary and the prescription goes to them. That's because there's often a bit of to and froing between the pharmacist and the clinical team on the ward, kind of resolving queries and checking, does the patient actually need all these medicines if they've only been in for 12 hours, etc. That's all resolved really quickly on the ward when the pharmacist's there. So you can see there the clinical review as well. It took 13 minutes when the pharmacist on the ward because they were there with the patient. They could resolve the issues themselves. Whereas if they were in the dispensary, it took over half an hour to do that, again, because of that toing and froing. We also found, so we used a tool that has been developed by King's College Hospital, which reviews the impact of pharmacists' intervention. So using the intervention log, we're able to show not just we're having, we've seen more patients, but the quality of the care we were giving to the patients was better when we were on ED. So from the graph, you can see from the yellow line that we're more likely to make significant interventions that were more likely to have benefits to patients' care and keep that out of hospital. And that methodology has now been validated. It's showing that that leads to a cost avoidance or cost saving for organizations as well. One thing to also point out is that by being on the ward, we were less likely to make contributions that either led to harm or had no significance. And the data suggests that by having a dispensary or remote service, you're more likely to kind of make changes that don't really make a difference or could potentially have a negative outcome for the patient. What that's led to, particularly at Leicester, is an uplift in the number of pharmacists working in acute medicine and pharmacists working in A&E and acute frailty as well, which is great. When I worked there, noticed a massive difference when receiving patients onto wards in terms of them having been seen before they arrived onto the ward because they'd been seen earlier in the admission. But then kind of expand a bit further. So thinking about our role in primary care, we wanted to look at our cross-sector cellulitis pathway. So in Leicestershire, if a patient's got cellulitis that isn't responding to oral antibiotics or it's clinically too severe to want to start on oral antibiotics, there is a pathway where we can start on intravenous antibiotics in hospital, but also in GP practice, and the patient stays at home for that initial intravenous therapy and then gets switched onto oral. So to tie it all together, in GP practice, the ticaplanin, which is the antibiotic we used, was prescribed on FB10s and then dispensed by contracted pharmacies and then administered by nurses in the community. In hospital, we would initiate it and discharge the patient with the teicoplanin. So we had two completely disparate data sources that we needed to kind of get that data out from. So we use the EPACT system. So that's the online database where all the FP10s are stored. So I mentioned it at the with all my different data sources with pharmacy. So that's the system that the NHS Business Services Authority use. So we were able to identify all the prescriptions and FP10s for teicoplanin that had been dispensed within, issued within a certain period. And then using the FP10 number, we're able to request the NHS number for that individual patient. Obviously, with the hospital dispensing system, we're able to see the NHS number straight away and extract that automatically from that. So we use the NHS number to then, and also the date of issue of the teicoplanin to get the appropriate discharge letter. And from there, we could see why the hospital had started it in terms of indication. We could also look at what advice had been given to the patient, what are the conditions they had, and what are the medicines they were on. And similarly, we could get that information from the GP records from those that were started in primary care. So we could find out what comorbidities they had. We could find out the kind of documented indication from the journal. If you're using system 1, that's what it's called, the tab journal. We could find out why the patient was given it, etc. One of the things we also wanted to look at was the route of administration. So the pathway at the time allowed for either intravenous or intramuscular injection. So we wanted to see how that was being used across the system. And then obviously we looked at the microbiology laboratory system as well, just to make sure that patients hadn't been given teicoplanin for an organism that it wouldn't have been effective for. So by linking all that data together and pulling it together, we found there were patients who were being given it for incorrect indications. So there were patients who were being given it for diabetic foot when it's for just plain old cellulitis. And there were patients who potentially had more severe infections that should have either been admitted for review of the differential diagnosis, or they should be admitted for a different treatment altogether. There were disparities in obese patients. So there were a number of patients who were, I guess, outside of the guideline in terms of their weight, and they were given inappropriate doses of teicoplanin that probably wouldn't have been effective for them. One of the follow-on pieces of work that we're planning to do is, now that we've updated the guideline, is see if that's reduced admissions because of these incorrect indications and incorrect doses. We also find linked to both the dose and the obesity of the patients was inappropriate routes of administration. So there were patients who were getting intramuscular injections prescribed, but because they were so obese and the way that the teicoplanin was being administered, it wouldn't have been intramuscular. So that drug would have just sat in the fat tissue, for example, and not treated the patient appropriately. But we had patients getting very big doses given intramuscularly when we prefer to give that as an intravenous infusion for teicoplanin. So there was a risk there. So by doing this piece of work, we completely rewrote the pathway in the guideline. We've done education both for the hospital practitioners and for primary care, and that's now been bedded in, I think, about 18 months. So like I said, the next plan is to redo this piece of work, tie it all together, and then look at the whole patient journey. So patients who are given teicoplanin, using the NHS number, we can then look at the data warehouse to see if they're admitted and what for, and see if we're able to identify any kind of gaps or risks that are leading patients to be admitted when they are started on the cellulitis pathway. So that's just two examples of how we're starting, not just within hospitals, but across the whole health system, to bring all our different bits of data together to make sure that we're providing the right care for patients. What's the future? For me, it's looking at stewardship, antimicrobial stewardship, so it's best use of antibiotics for everyone across the whole health system. Pharmacy First has launched, so we've got pharmacists and community now who are using set care pathways to determine whether a patient can have an antibiotic without seeing a prescriber. We've also got GP practice prescribing, and we know that the vast majority of antibiotics are prescribed in GP practice, either by a GP or a nurse or a pharmacist within GP. And then we've got hospital and urgent care. So some of our urgent care providers are private, some of them are within NHS institutions. They're prescribing often either on outpatient prescriptions or green FP10 prescriptions. And there's nothing that's bringing all of them together. I think for the future, like I said about the all singing, all dancing hospital systems, some electronic prescribing systems now bring patient level biochemistry, laboratory data, microbiology data together and look at their GP records as well. That's exciting. One, for bringing data together, but kind of streamlining care. Are we ever going to get the same for primary care? I don't think so. I can't see that happening at the minute. So being able to maybe use things like AI and machine learning in future will be really important and bring those massive data sets together. That is something that the UK Health Security Agency is looking at in terms of antimicrobial resistance, is using AI, machine learning, and big data to bring all these different data sources together to even drill down to patient level data, which is quite exciting. One thing that's coming through as well is pharmacy informatics specialists. So some of the bigger hospitals will have an informatics team. And I know now the regional NHS offices are in particular hiring pharmacy technicians who've got an interest in data and informatics and data analysis to support this kind of work. But I think for me, working in academia, this is a skill we probably need to be increasing within our profession because we are one of the professions that can use data to improve patient care, particularly around use of medicines. Okay, so that's me. And that's just a little bit about School of Pharmacy. And if you want to contact me either on social media or email, my details are there, and I'm happy to take questions.